You alluded to this. So patients are coming back for multiple injections, right? This isn't a one-time stop shot, right? So what's the schedule like, Dr. Chandra? How do the patients come through? Is it every 2 weeks, 3 weeks, month?
Yeah, that's a great question. So, initially when one is started, based on the trial that was done, as well as the current trials that are ongoing, the person receives kind of what I call a test dose of RP1 with Riad. And then 2 weeks later, they come back for, again, RP1, this time with the addition of nivolumab. And that is repeated every 2 weeks for 8 doses or 8 cycles. And then after that, potentially the RP1 totally falls off, and then it's just nivolumab once a month. But there is some verbiage where there can be some further discussion about perhaps re-adding the RP1 a little bit later down the road. And to, Riad, your earlier point of documentation, it's so key. I'm so glad you focused on it. I mean, site selection is a big deal. And I think we should be humble enough to say we don't quite understand the biology necessarily to figure out what is the best to select, right? Should we do a lymph node versus a liver versus a lung? We're not quite sure. And so I think the overall principle is we should rotate as much as we can. We should try to get that drug to be seen by as many of the melanoma tumors as we can in order for that to be successful, having clear documentation by our colleagues. And so intra-colleague and inter-colleague communication can be just clear and succinct and without any uncertainty. I think that's really key.
100% agree. I think it eliminates so many headaches, and we don't appreciate, an extra 5 seconds to be as specific as possible eliminates such a drag on the back end.
Let me add one thing to that too, Tyler, is that to what Sue was saying, this is also different from the IR perspective is because I'm very likely to upfront schedule the patient for several injections now. So she's a patient, he or she would be on the schedule today, in 2 weeks, in 4 weeks upfront, right? So you're populating your schedule now, which is different. We don't have many treatments where we do that several times. I mean, oncology does that because of the cycles of therapy that people get, but this is new for us. So again, we're populating our schedule up front. It's all about being proactive and being prepared for that patient. But again, another part of the workflow that is the interventional radiology community as you practice IO have to adopt.
I like that. Now, they're going to get nivolumab at some point in the process of this cycle. And does Nivo have to be given on the day that they are injected? And because, for somebody who's traveling, that might be very convenient to have if they're traveling an hour, 2 hours to come see you guys, it might make sense to do it on the same day. But does it have to happen? Let's say they're local and waiting to do 2 visits might occupy an entire day. How does that work out?
Sure. I mean, ideally from the patient's perspective, I imagine most would love for it to be done all on the same day and then they can go home. But I think it is nice to be able to have a little bit of wiggle room there. So there's a 3-day window for these drugs to be given. So, if Riad injects them on a Tuesday, I can still inject them on that Wednesday and still be within the parameters of the trial.